How are you? Good.
Yeah.
So we have a test coming up next week, right?
Yes.
And you have a quiz today in lab,
Yes.
correct?
Yes.
We should know about that, right? Okay. So I'm going to try and get through this pretty early so you have time to go collect your thoughts before your lab quiz. Despite how I sound, I did not cancel class on Tuesday because I was sick. I wasn't sick until Professor Emmons texted me saying, "Are you sick? Are you okay?" I was like, "No, I'm fine." Maybe now I am. We had a death in the family, and it's fine. He had a very good, happy life. It's fine. We're fine. But I have an aunt and uncle who came out here to avoid the snow and the cold back in Iowa, and that's where the death of the family was back in Iowa, and they don't have the money to fly back, so they were feeling very guilty. So Tuesday I said, we're gonna do something that Uncle Tuffy would want. That was his name, my Uncle Tuffy. We're gonna do something that he would want us to do, and we'll celebrate him in that way. So I took him to the USS Iowa battleship in the LA harbor. Have you been there? It's actually pretty cool, I have to say. So I recommend it. We had a good time together. So the respiratory system, we're going to go over the general functions. I will then tell you what the upper respiratory tract is versus the lower respiratory tract. With the sound of my voice, can you predict which respiratory tract is my problem right now? It is upper, for sure. It's a river of phlegm, and I wish I could just ear, nose, and throat. Just take that part out, and then it'll be fine. Then we'll actually go down into the lungs, and then on your homework packet, the 4 pages of supplements, we're going to go into Boyle's Law, which is, it's a portion of the ideal gas law. Maybe that's something new to you. I know, you're saying no. But for some of you, it might be new. And that's a little bit of physiology. I would like you to hear a little bit of the physiology of the respiratory system. That is a system we cover last in physiology because it's the hardest system. Respiratory system is the hardest physiologically. Anatomically, it's a breeze. Physiologically, it's very tough. And I'm going to tell you about the innervation of it and also some pathological disease states. So, upper versus lower respiratory system, conducting zone, respiratory zone, what does that mean? Okay, so upper respiratory tract, as you can see here, is the nose and the throat, but actually there's 3 parts of the pharynx. There's the nasopharynx, there's the oropharynx, and then there's the laryngeal pharynx. So the upper respiratory tract goes basically to the level, you follow this line across, to the hyoid bone. That's the upper respiratory. Lower respiratory tract is from the hyoid bone, basically, or your glottis, your epiglottis, down. That's how physicians like to describe it clinically, anatomically, physiologically. That's not how we distinguish the 2 areas. We say conducting zone and respiratory zone. Conducting zone is just air passage ways. Conduits get air deep into your lungs. It's not until the structures get so plentiful and small enough to allow for gas exchange that we as anatomists and physiologists say now we're in the respiratory zone. Most of the air you are breathing in right now, it's about 500 milliliters, so will you hold up your water bottle for me? Every breath you take in and out is about 500 milliliters. That's the amount of volume in that bottle. Thank you. And of that amount of air, breathe in 500 milliliters, breathe out 500 milliliters, breathe in 500 milliliters, breathe out. 150 out of 500 actually is trapped in the conducting zone. Air passageways that are too few and thick in distance that they prohibit gas exchange. It's not until we get to the lower regions inside the lungs where you can now have gas exchange. For anatomists and physiologists, that is very distinguishable. So that's why we say conducting zone, which is most of what you're seeing here. It's not until you get to the very small structures where you have gas exchange. That's our respiratory zone. So conducting zone goes from your nose, because no one's mouth breathing, right? Not allowed to mouth breathe. From your nose all the way down to the terminal bronchioles, and I'll show you what those are. Terminal bronchioles are the last part of the conducting zone. After the terminal bronchioles, we're going to have respiratory bronchioles, and I'll show you what those look like. They're going to lead to alveolar sacs, alveoli, alveolar ducts. In those structures, we can have gas exchange, so that's why they're called the respiratory zone. Upper respiratory tract and lower respiratory tract, that's mostly used in a clinical setting, not so much in the classroom. The functions of the respiratory system, respiratory, tomato, potato. Let's call the whole thing off. No? No one knows that song? Garage. When you're married to a British man, these are the things that you have to worry about at night. Anyway, the respiratory system is responsible, obviously, for ventilation, getting air into and out of your lungs. That is called external respiration. Getting air in and out of the lungs. That's external respiration. The gas exchange that occurs in the lungs is also part of that. Then the oxygenated blood needs to be delivered to tissues of the body. Gas exchange occurs again across the blood and the tissues of the body. That's internal respiration. When cells actually use the oxygen to help make ATP, that's called cellular respiration. And I beg my students to know the difference. Respiratory system is important for smell. We know from Unit 1, your ethmoid bone has the cribriform plate with the olfactory foramina. Remember that? And the olfactory nerve endings actually dangle through those holes. And that's when you breathe, the nerve endings actually collect some of the chemicals in the air, and your brain interprets them as smell. It's also important for speech. How many of you remember the movie Dumb and Dumber? Arguably one of the best movies ever. There's a part where Jim Carrey goes, remember that part? Where the bad guy was sitting between him. And that was not scripted. That was completely ad lib. And he said, do you want to hear the most annoying sound the human body can make? Do you remember? And he well, that is resonation. That sound that he was making, he would not be able to do that without his nasal cavities and chambers and that sort of thing. So it's important for speech. Weird to think that the respiratory system can actually be influencing the blood and your blood pressure. So weird to think about that. In physiology, we actually teach renal and respiratory systems together. It's the last unit. Those two are the hardest systems ever. We don't start out with them because I would only finish with like 2 students at the end of the semester if I did that. It's the hardest system, renal and respiratory together. And they do work together to regulate blood pressure long term. So weird to think that in your pulmonary capillary beds, and I'm going to show you a picture of that, there's an enzyme there called ACE. It stands for angiotensin converting enzyme. And it's that enzyme that actually will take a precursor, a preliminary form of something, and then convert it into an active form. That's angiotensin 2. How many of you have high blood pressure? Yeah, because every year there are fewer and fewer people in my class that are my age. I have high blood pressure. I'm on blood pressure medication. I'm on an ACE inhibitor. It's called lisinopril. And an ACE inhibitor targets the enzyme in the lung called ACE. And when my medication, when I take it, I'm inhibiting that enzyme, and it helps lower my blood volume and my blood pressure, keeping it more in normal ranges, less dangerous. Because it's in the lungs, this enzyme, a side effect that 10% of the people can get when they take an ACE inhibitor, and that's the gold standard these days to treat high blood pressure. They get this annoying cough within about 20 minutes after taking their medication. So I love going to the gym, being on the treadmill, and hearing all of the people my age who are trying to work out, and they're on their ACE inhibitors. I can hear all of them doing that. Anyway, yes.
So what was the function of the enzyme?
The enzyme, okay, so when you get to the renal system, it'll make more sense. It's kind of the cart before the horse at this point. But your kidneys are the ones that need to maintain your blood volume and your blood pressure long term. If they're unhappy with your blood volume and blood pressure, they will release a chemical signal called renin, R-E-N-I-N. This goes into the bloodstream, and renin will cut a plasma protein called angiotensinogen into angiotensin 1. Angiotensin 1 is a very small protein. It's only like 10 amino acids long. This angiotensin 1 floats through your body, and when it gets to your pulmonary capillary beds, this enzyme that's found there, called angiotensin converting enzyme, ACE, cuts that angiotensin 1, cuts it into a smaller peptide called angiotensin 2, which is a very powerful vasoconstrictor. All your blood vessels do this, and that's what causes your blood pressure to go up. So someone who has high blood pressure, the first medication that they're going to try is usually an ACE inhibitor. You're welcome. Also, special movements. Weird to think. How many of you pooed today?
Not yet.
I don't know.
Really?
I don't know.
Look, shit, shower, shave. Not necessarily in that order, but that's what we do, pals.
That's real.
You need your respiratory system to help you with pooing. What do you look like when you poo? And I'm not kidding you. In physiology, we do an experiment where you have to pretend that you're pooing. I'm not kidding. Huh? Even if you have the squat, and look, I don't have the squatty potty, but I have a drawer, and I actually pull it out and I put my feet on it because it just makes it so much easier. But you know what? If you have a healthy diet, you don't need a strain to poo. Like just a cup of coffee and it's fire in the hole. Just yeah. If you look like this, you ready? If this is you, that is very unhealthy, and it can cause you to die. So in physiology, we actually have an experiment that we have you do to train you how to poo right. I'm not kidding. It's a safety issue. It's a public safety issue. You used to know how to poo correctly. You don't do it right anymore. You're holding the valsalva maneuver too long. The valsalva maneuver is this. And I know what you're thinking, like, if I just hold it and keep pushing, I feel it. That's not what you're supposed to do. But Brandon, you knew how to poo correctly before. No, seriously, it's a public safety hazard. Pooing. When you were little, you knew how to do it correctly. How many of you have little ones that you look after, that you babysit? Are you okay? When a toddler is actually ready to be potty trained, they will show you, they will demonstrate to you that they are ready to be potty trained. And the classic sign is they recognize that they know, they feel, okay, something's happening down there. They feel the pressure. And you know they're ready to be potty trained because once they feel that, if they actually go and seek privacy, then that means to you as a parent or a caretaker, they have enough time where you can say, okay, let's go to the bathroom, right? Because they are now aware something's about to happen. I want privacy. And it'll scare the crap out of you at first because they'll be watching TV and you'll be doing the laundry or whatever chore you're doing and you can hear them, and then all of a sudden it goes deathly quiet in the house. You're like, oh shit, where are they? And they have gone to seek privacy. And it'll scare you, and if you're quiet and just listen. From behind the couch, behind the door. Seriously, that's what you're going to hear. It is true. And they're pooing correctly. They're not going, they're breathing through their downward. For those of you who have not had children yet, when you actually have to bear down to push out this baby through the vagina, the doctor will frequently say to you, you're not pushing right, you're not pushing. And you're like, what the hell? I am pushing. They don't want you to look like that. That's the valsalva. They say, breathe through the push. What the hell is that? They want you to be a toddler again. You don't hold it, you're releasing the air. It's on a somewhat closed glottis. That's how they describe it. So from now on, ladies, when I go in the bathroom, and I know what you're doing, it's so cute. You all try and hide the fact that you're going big potty. Here's how you hide it. You keep flushing over and over again. Or you're like, grab the toilet paper, grab the toilet paper, grab the toilet paper. It's just toilet paper sounds over and over and over again. Just get it up. Just and then, fine, everyone poos. There's a book. I'll bring the book in. It's called Everyone Poos. I'll read it to you. Yes. And here's why. Because when my boys were younger, it used to annoy the hell out of me. I'm in the bathroom, right? And they're in the door. Mom, what are you doing in there? I'm cooking dinner. What are you doing? So if I'm, then there's no reason to ask the question. You know what I'm doing in there. But mostly they do that. Children do that. They wait for you to be in the bathroom. It's funny because when they're young, you have to bring them in the bathroom with you because you're worried about the shit that they'll get into. And then when they're big enough and you can go potty again by yourself, it's like a vacation. You look forward to your big potty times. It's a vacation. It's like a cruise. And they wait until you go in there. Mom, what are you doing in there? I'm pooing. I'm going big potty, okay? And that's when it's like a confessional. Because the door is locked and they know you're preoccupied for a while. That's when they want to tell you shit. Look at the moms. It's true. That is when we get most of our conversations out of our children. Because they know you can't throttle their throats anytime soon. And it's a confessional. It's like the door is closed and I can just tell you stuff through the door. The valsalva maneuver and the release of it. If you ever think you're having a heart attack, doing that maneuver like that can actually buy you time, and it might mean that you survive your heart attack. So that is how you're supposed to go through your bowel movements. If you are straining, your heart rate actually goes up. And as your heart rate goes up, we know that then that means the heart gets less and less perfusion, less oxygen delivery. So you're making your heart work harder and it's getting less blood delivery. You should not be pooing like that. And so if you get to physiology, be ready. You're going to do an experiment where we train you how to poo correctly. It's a public safety issue. Most people don't know that. Breathe through it, Brandon. Poo loud, poo proud. Poo loud, poo proud. Breathe through it. Nose and nasal cavity. Okay.
Thinking of the Austin Powers references, right? Who does number 2 work for?
Or the Dumb and Dumber references. Or was it Harry? Which one's Harry and which one's Lloyd? Harry is
The one with hair. Yeah. Right?
They both did. The blonde one, Daniels.
Yeah.
Anyway, remember where Lloyd gives him the laxative and he goes to pick up the lady to go out on a date and he just
Oh, yeah.
Harry, that toilet's broken. What are you doing? What are you doing in there? Shaving. Awesome.
I need to go watch that.
It's homework for this weekend. How about that? So go ahead and put your finger. Go ahead. This is the one time you're allowed to pick your nose. In the vestibule. Vestibule means waiting space. So your finger's waiting to go deeper. That is not the only place where you find a vestibule. Ladies, you have another vestibule. You have another vestibule. You'll learn about that in more detail. It is the space between your labia minora, your little lips. Okay, remember, vagina is big lips, and there's a second set of lips. That's labia. So ladies, we've got 3 sets of lips. One I'm seeing right now. The other 2 I don't want to see. Please. but the space in between your little lips down there, that's the vestibule as well, the waiting place. And yes, Brandon, you will wait until we say, okay.
Yeah, well,
That's
generally that's the rule.
I was telling some people in the office that I seriously, until yesterday, I did not know what hashtag meant. I did not know what that meant. And when everyone was like, hashtag me too, when I first read that, I thought it was like, pound me too? That's some forward thinking people. I want to be part of pound me too. I didn't know. Well, that's what it means to people my age. Like, that is an awesome club to be part of. And my sister's like, no, it's not what you want to be a part of. So it wasn't until last night where a student of mine said, let me explain what this whole hashtag and what trending means. I said, please, I don't get it. She said, I'm going to talk to you like you're my mom. I said, perfect. Awesome. Now I know. I didn't know what it was. So I've now downloaded the Instagram app. Because I didn't know.
I thought you were blocked.
I am for my personal email, my Gmail account. But if I use a different account, I'm not blocked. I have 3 followers. I can give a shit, but I have 3. 2 of them I know. 1 I have no idea. And one of them is the IT tech guru person for the whole campus. So he emails me. He's like, we need to talk. Your security settings are not set stringently enough. It's fine as long as you don't ever post anything. And I know you never will. But if you do, you and we need to have lunch, is what he told me. Okay, we'll have lunch. I have no idea. Anyway. So up here in the vestibule, you've got hairs. The hairs, they collect dust and particulate matter, which is a way for us to entertain ourselves on the way home. No one else picks their nose on the way home? When it's dark and no one can see you. It's highly entertaining. Those hairs are called vibrissae. And as you get older, they do get, you can braid them. It's like, where'd that come from? Vibrissae. Mm-hmm. Then back here, if you can stick your finger even further, you would feel those bumps. Those are nares. And you've got 3 of them. Sorry. Here are your nares, the openings. Going back through your nares, these are conchae. That's plural. Concha is singular. You have a superior, middle, and inferior. And they actually have erectile swell bodies. Weird to think, guys, that more than one place in your body actually gets erect and swollen with blood. Ladies, for you too. It's in your nose. And they swell up with blood. Breathe through your nose right now. Is one nostril easier to breathe through than the other one right now? Did you ever notice that?
Yeah.
It's because one side, if your erectile bodies in these conchae are swollen, then less air can get through because you have a smaller diameter for air to pass through. And then give it about another minute, do that again, the other side should be easier to breathe through. So they switch back and forth, which one is swollen with blood. And the reason for that is to humidify the air before you breathe the air down into your lungs. Okay, paranasal sinuses is not the first time you've seen that. FEMS, frontal, ethmoid, maxillary, sphenoid, that's where we have the sinuses. They help lighten the weight of your head. I already told you about the olfactory receptors going through the olfactory foramina of the cribriform plate. Your nose. Everyone has a different size nose. It all depends not on the nasal bone, but the cartilage. Cartilage, remember, is heavily dependent on steroids, like testosterone the most. That is the reason why men usually have a bigger nose, unless you were, of course, Michael Jackson, in which case, yeah, who knows what's his. I like to think that he's up in heaven right now. And the angels up in heaven are like, Michael, yes. We've got some of your body parts for you. Okay. Is this nose yours? Yes. What about this one? That's Latoya's. It's just my little happy place. Very few people even know who I'm talking about anymore. The skin in your nose is thin. It's thin. So if you start digging around with your claw, your nail, you can actually cut through the skin and then you're going to bleed. You also have sebaceous glands in there. That means you can get a zit in your nose. Have you ever had that? Mm-hmm. It's the zit you can't pop, and you feel it, and you're like that. You're like trying to pop it, aren't you? Look at some of the people. Like, no. She's like, no, that doesn't happen to me. But yes, you can get a zit in your nose. External nares, that's what I asked you to put your fingers in. That's your nostrils. In between the two nares, we have the nasal septum. It is formed by the perpendicular plate and the vomer, perpendicular plate of the ethmoid and the vomer, right? The two of them come together. On the bottom of your nasal cavity, we have the hard palate, and if you keep going back, it turns into the soft palate. So now you can stick a different finger in your mouth. A top hot hair, that's your hard palate. And if you stick your finger further back to get to the soft squishy part, you will vomit. And that's your soft palate. So don't do that one, at least not in front of me. Vestibule, the waiting spot, right up here, this area right here is Kiesel box area. This is usually where little kids are digging around with their little fingernail claws. It's heavily, very much vascularized. That means a lot of blood vessels. So if you go digging around here, you're probably going to have an epistaxis, which is a nosebleed. The vibrissae, the hairs. Nasal concave told you about the erectile swell bodies. And back at the end of your nasal cavity, back here, this is the beginning of your pharynx, your throat. This region is called the nasopharynx. We also have different structures in the back here. We have a tubal, we have tonsils, and I'll address what tonsils we have back there. Just a minute. Going all the way back, if you could actually shove your finger all the way back until you hit your throat, you would go through another set of apertures to hit your throat. Those are called the posterior nasal apertures. Most of us don't pick our nose that far back, not to be recommended.
Can you explain like a deviated septum?
So a deviated septum is just basically the septum has a hole in it. So you have communication from one side to the other where there shouldn't be communication from one to the other. Another way where you can have a problem with the separation between the mouth and the nose, cleft palate, cleft lip, cleft palate, or a hard palate did not fuse correctly. So a deviated septum is between here versus cleft palate is a problem with hair. And when babies have a cleft palate, they try to breastfeed, for example, it goes right out their nose, right? So we have to give them the tube that goes back further and feed them that way until they are big enough where we can surgically repair it. Does that help? It's just separation. Bone did not form right, the barriers did not form right.
I had to get mine corrected.
To to shift everything over and then allow it to re-heal. Yeah. All better now though? I bet you instantly probably knew, tell the difference too.
If you want me to do this, you can tell the difference from the other way.
Mucous membranes, well, we have that in the nose. That's awesome because we inhale a lot of particulate matter. We have a lot of goblet cells that are in there as well, and they're releasing mucin. This is found even back down through the regions of our pharynx. With all this mucus, phlegm, that's what I'm having a problem with now. It's like a river of phlegm going down my throat. But all of that phlegm, all of that mucus is catching particulate matter. And you have the mucosa is pseudostratified ciliated columnar epithelium. And the cilia are little hairs that are going to sweep the mucus and anything trapped in the mucus superiorly. And when that happens, that's called your mucociliary escalator. And this happens even in you right now, even though most of you are not sick like I am. You get some of this sweeping up, and then you don't even realize you're doing it. You're like, and you swallow all that stuff down, and now you're digesting that mucus and all the particulate matter. Think of it like free food.
Calories?
Well, the mucus, not enough to live off of.
Yeah, I go, I'll make a track.
But have you ever had so much mucus and phlegm and you kept swallowing it that by the end of the day you actually didn't want to eat anything because your stomach felt so full and then you knew it was like, it's all mucus down there. No. Lamina propria is just basically a sheet of proteins that helps anchor the cells down. So right here is the lamina propria. And in this area, we can have immune system cells like T cells and B cells that help protect us from bacteria. Pharynx, 3 parts. We have the nasopharynx, oropharynx, laryngopharynx. They're shown here in different colors. Nasopharynx, basically from the nasal cavity down to the tip of the uvula. Oropharynx from the tip of the uvula to the level of the hyoid bone. Laryngopharynx from the level of the hyoid bone until you get roughly to the entrance of your larynx. The opening of that is called the glottis. The kind of epithelium you find along those 3 areas changes depending on how much friction they're exposed to. For example, through your nose, you should only be breathing, right? Air. There's no frictional rub from that. So it should be a type of epithelium that doesn't have to withstand friction. But your oropharynx is definitely going to have to withstand friction. So it's going to be stratified squamous epithelium to withstand that. In other places, it'll be pseudostratified ciliated columnar. Laryngopharynx also stratified squamous epithelium because you're swallowing. Have you ever eaten a potato chip and you didn't chew it all the way and you feel that jagged edge just scrape all the way down? When that happens to you, go, thank goodness I have stratified squamous. It will replenish, it'll grow back, I'll be fine. But have you ever swallowed something, a drink, and someone made you laugh and you shot it out your nose? It burns like a mofo, doesn't it? And then when that happens, you should say, dang it, I have pseudostratified ciliated columnar, which is really a single layer, not stratified. So I wish I had stratification because then it wouldn't burn as much. Be sure to think all that next time you shoot soda out your nose. So again, from the soft palate, the tip of it is the uvula upward. That's your nasopharynx, pseudostratified ciliated columnar. There is a 90-degree turn. That means anything you breathe in is going to hit this back wall. And on the back wall, we have a tonsil, the pharyngeal tonsil. And right here, we have a tubal tonsil. So there are two tonsils that are filled with lymphoid tissue, which has B cells and T cells ready to attack anything that you happen to breathe in. You definitely don't want to be a mouth breather. You want to be a nose breather for those two tonsils to do their job. Pharyngeal tonsils are also referred to as your adenoids. How many of you had your tonsils taken out? And I was going to say, for sure you did if you had deviated septum. Yeah, for sure they were going to take that out. Did you? It's actually becoming less and less frequent these days because your tonsils are part of your immune system. We would prefer you to keep them. It's only if you get exposed to too many pathogens and get too many infections where the physician might say, and now it's doing you more harm than good. Let's just take them out so they can't keep getting infected. But there are two right back there, tubal and pharyngeal. The tubal tonsil surrounds the opening, or the exit, I should say, of the auditory tube, your pharyngotympanic tube. You'll learn about that more when we get into our special senses. That's lab unit 3 that you're soon getting to. It's weird to think that your ear, your eustachian tube, opens at the back of your throat. But if you've ever fed a baby, you know you should actually feed them with their head a little bit up. You don't want to have them too far back because as they drink, some of the milk can splash up once they swallow and actually get into that tubal tonsil area and get into their eustachian tube. And now you've got milk in this warm little canal, and then they get ear infections, middle ear infections. So you're supposed to hold them up. In babies, their eustachian tubes are more horizontal like this, less slanted like ours. So if you don't hold them up just right when you feed them, there is more likelihood that the milk is going to get into that eustachian tube. Okay. Oropharynx. This is from the tip of the uvula to about the level of the hyoid bone. It's the oropharynx. We have stratified squamous epithelium there because when we swallow, there's a lot of friction, abrasive forces. There are also 2 more tonsils here. There's one at the base of the tongue called the lingual tonsil. And there's one in the back. That's your palatine tonsils. And again, the palatine tonsils can get infected as well. That's part of the reason why when you say, I'm sick, I've got a sore throat, they're going to take a visual, those palatine tonsils, to see if they're white and pussy and nasty. If they see evidence that they might be infected, they'll do a swab and actually test you for strep throat. Because we don't want to just hand out antibiotics, right? We want to make sure that you really do have bacterial infection causing the infection, not something like a virus. Antibiotics do nothing against a virus. Zero. Laryngopharynx. This is a passageway for air and food. So because it's for food as well, it's going to be lined with stratified squamous epithelium. It goes all the way down to the level of the cricoid cartilage, and I'll explain what that is when we learn about the larynx and all the cartilages that we see there. So there are 9 different kinds, 9 different cartilages in your larynx. Find your Adam's apple. That's what we call it, right? There's no apple, it's actually this largest cartilage of your larynx is called the thyroid cartilage. And where it kind of tends out, that's called your laryngeal prominence. So Adam's apple is really your laryngeal prominence of your thyroid cartilage. Right below that is the cricoid cartilage. If I could turn this around on the back, We see more cartilages. We see the corniculate and the arytenoids and cuneiform. Cuneiform, they look like little slender slivers. Corniculates, they look like they're horns. That's what corniculate means, horn. And then the arytenoids, those are the ones that are actually anchored to your vocal cords. And so when you are speaking, it's the arytenoid cartilages that are moving from that. The types of cartilage, are they hyaline? Are they elastic? Then also right here, this is the last one, the epiglottis. Well, I tried to color coordinate them. Anything in pink is hyaline cartilage. Anything in blue is elastic cartilage. Notice that the arytenoids are a blended both. They are hyaline and elastic. That allows them some flexibility, but also rigidness to help anchor your vocal cords into them. I'm going to show you this.
You know the NG tube, the one that goes up your nose, like what's like the pathway that it like travels down into your stomach?
They're sticking it through your nose
I've had one before.
all the way down. Have you been awake when they inserted that? What do they tell you to do?
Drink water.
They tell you to keep swallowing, don't they?
Yeah, like you need water.
So as you kept swallowing it, that was important for them so that the tube didn't go down into your larynx, into your lungs, that it would stay posteriorly and actually get to your stomach. That's why it was, and it's very uncomfortable, isn't it? No. And when they take, when they take it out, it's like that whole area is scrape sore. That's why you sound raspy. If anyone has surgery and they have to intubate you, it's the same kind of thing. You sound raspy for about 2 weeks because of that tube being inserted. The intubation is going in the other way, right? It's going into your air passageways. That's why for the NG tube, it's important that you be awake so that you can help them with that. Swallowing ensures that the tube goes behind. Let me show you. So when they are shoving that through here, the tube's coming down this way. You swallowing, make sure that the epiglottis, when you swallow, all of these muscles in the throat pulls the larynx up. The epiglottis folds over this opening. And the more you swallow, the easier it is for them because it ensures that the tube stays down and goes into the esophagus and then into your stomach. And it's not fun. Yeah. So this is a superior view of your glottis. The glottis is actually the opening where your air now is going into the larynx and the air passageways of the lungs. The epiglottis is called the guardian of the airway. When you swallow, your throat is pulled up, the epiglottis folds back, and any food you are swallowing stays posteriorly and will enter the esophagus and not into your air passageways. You do not want to aspirate what it is that you're eating. If you aspirate something into your lungs, you can choke. It also can lead to an infection. True story. They thought a man had lung cancer. They could see growth when they did x-rays and that sort of thing of something growing in this man's lung. When they went in to do some surgery trying to remove some of this mass, he didn't have cancer. He actually had aspirated a raw peanut, and the peanut, the seed, germinated in his lungs, and he was growing a peanut plant in his lungs.
Did he keep it?
And they, no.
They actually watered it.
So your true vocal cords, they are avascular, so that means they're white, true vocal cords. But you also have false vocal cords that's really folds in the mucosa, vestibular folds. they help you with your valsalva maneuver. So when you're doing the valsalva maneuver, trying to go big, your pooping face, you actually push these vestibular folds over the glottis. And that's why when you're trying to exhale but your glottis is closed, and you grunt, then you're opening the vestibular folds a little bit to let that grunt come through. Now, Brandon's looking at me like crazy.
I'm pretty healthy, so I usually have pretty nice poops. So, pretty probiotics. Full daily servings of superfoods every day.
No straining.
No, not really, no. Unless I have like a mega bad cheat meal and I just like, fuck my stomach up. Which does happen once a week. Sugar kills me.
So you don't mind that I'm posting all this on YouTube, right?
No.
Okay, good.
My address is 259.
So, true story. I'm talking about the larynx, and this is a superior view of your larynx. Here are your true vocal cords, and the vestibular folds are to the side of them. I had a student fall asleep in my class. Who would do that? It was so entertaining. They woke up, and I had this picture on the screen. And this guy says, wait, whoa, whoa. I thought we were talking about the respiratory system. I was very confused, and I said, I am. Well, then why do you have a picture of vagina up there? Every single female in the class just kind of turned and looked at her. And I said, you should probably not drop the class. You should stay around until I get to the female reproductive, because that is not, I mean, we have curtains, but not like that. We don't have curtains that open and close the whole. We have, and the curtains, they go really wide when that baby is like, they get real wide. But our little lady does not have like open and close from like, we can't sit there and close the curtains right now, ladies, right? Innervation of your larynx is from a cranial nerve. Cranial nerve number 10, which is called your vagus nerve. And it's called the recurrent laryngeal nerve. And when you actually open up your cats and start dissecting the blood vessels around the subclavian blood vessels, you'll see this nerve looping around the vessels and going back into the larynx. If you're lucky. If some other class actually opens up the cats before you do, it'll get cut. Everyone thinks, oh, it's nothing, it's connective tissue. I love it when I teach lab, because when I tell you to open up the cat, I'm like, don't look. Before things get destroyed, here, I want to show you some nervous tissue, because when the class starts dissecting, it's gone. Is it already gone?
Yeah, I went in there.
Anyway.
This is the first day. The substitute teacher mishap. I just took it on my will to just do what he was doing.
Yes, things happen. Anyway, I bet if I still go in there, I can still find the recurrent laryngeal nerve on your cats. Loops around the subclavian vessels and goes right back into the larynx. That's why anatomists call it recurrent, because it went further, and then as if it could talk to you, it would say, oh my gosh, I forgot to go to the larynx. Let me go right back. Recurrent laryngeal nerve, a branch of cranial nerve 10. If you damage cranial nerve 10, you will have paralysis of your larynx muscles, and you will have a weak voice. Maybe only one vocal cord can move, the other one can't.
I have a question. This is not completely about this, but the phrenic nerve that goes to the diaphragm and it goes through C3, 4, and 5. So like diaphragm helps us breathe, right? So when let's say that nerve gets injured,
Sucks to be you.
so what happens then?
You need to be on a ventilator if both get damaged. If one is only damaged, you can somewhat breathe, but you'll be struggling even more.
But you'll be all there, like not the coma.
You should still be there. People get C3, C4, C5, if they get cervical dislocation, their spinal cord breaks up here. They can still live, but they need a ventilator. Christopher Reeves is a perfect example of that. He was riding a horse, he fell. Well, he hit a branch, I think. Wasn't paying attention. Horse took off. Boom. And so he had to be put on a ventilator because the phrenic nerve was severed, basically.
And did they necessarily go paralyzed?
He was paralyzed from the neck down when that happened.
He still died early though, right? He still died younger than he should have, right?
For sure, he did. But he did an interview with Baba Wawa, Barbara Walters. That's what I call Baba Wawa. Hello, I am Baba Wawa. Tonight, we'll interview. I'm Baba Wawa. She interviewed him, and he actually wanted to be able to speak on his own, like breathe on his own. He took out his tube, but he had to remind himself to breathe, to physically like work at it. Most of us sitting in this room, we don't go, shit, I should be doing something right now. What is it? Oh, breathe. But can you imagine losing the ability to breathe on your own where you actually have to think about it? And that means you're recruiting different muscles to help expand the thoracic cavity. Yep. That's the last half of this lecture. We're going to talk about the mechanics of ventilation. Pretty cool stuff, actually. Going down to the trachea, we have cartilaginous C rings. They're called C rings because they're in the shape of the C, not O rings, which is awesome that they're not O rings because the back of your trachea, if I could peel this forward, and on your cat's going to do that, you're going to peel the trachea forward, and behind it is the esophagus, which is this muscular tube. If your trachea had O-rings, then when you swallowed your food, it'd be like hitting speed bumps, bump, 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 the whole way down as you were swallowing. The C-rings are made of hyaline cartilage. They are important to keep the trachea open in between breaths. Otherwise, your trachea would collapse because it's a mucous membrane. It would stick, and you would have a hard time on your next breath in trying to open up your trachea to allow for the next breath to come in. So the C-rings keep it patent, open. Down at the bottom of the trachea, we have branching into your right and left primary bronchi. That branch, that spot right there, if you could actually cut through the trachea longitudinally, open this up, fillet it open. The carina is actually a piece of cartilage, and it looks like a sailboat sail. That's what carina means. It's like a sail. Your left and right primary bronchi are actually different sizes, like in diameter. And that means if you do aspirate something, physicians know which one is more likely for you to aspirate something into. So if they have to go in and retrieve it, chances are it's probably in the right primary bronchi because it's a straight shot. The left it kind of curves this way because it has to go around the heart. And again, the trachea is lined with pseudostratified ciliated columnar. In this picture, you're seeing in yellow the cartilaginous C ring. See, it looks like the letter C. And it's made of hyaline cartilage. In Unit 4 of your lab materials, you're really going to be focusing on tissues. So I'm pointing this out now. The anatomy of the lung, the surface of it. Base is the widest part. The apex is the most narrow part. Happens to be that the apex of the lungs is actually the superior part. Hilum, can't see that in this picture, but a hilum is an indented region of an organ where vessels and nerves can enter and exit. So it's an indented region where things are coming in and out. We have fissures. On the right lung, we have the oblique fissure, as well as on the left lung. The right lung has another fissure called the horizontal fissure. So the right lung has 3 lobes. Left lung only has 2. And the left lung has what we call the cardiac notch, because that's where the heart is sitting, slightly to the left. So we have a superior, middle, and inferior lobe for the right side, and superior and inferior lobe for the left side. Lobules are hexagonal shapes that we see on the surface of the lung. Pleura, we've already talked about the membranes around the lungs. That was our first day of class, second day of class. We have visceral pleura and parietal pleura. Parietal, tightly adherent to the chest wall. Visceral pleura, tightly adherent to the surface of the lungs. You cannot peel the visceral pleura off. It just basically looks like it's saran wrap around the surface of the lungs. You need these pleurae in order for your lungs to inflate. If you actually disrupt the pleura membranes, you will not be able to inflate your lungs, and I'll explain why in just a moment. Going deeper into the lungs, we have the right and left primary bronchi. They branch to secondary and then tertiary bronchi, segmental bronchi, smaller bronchi. I don't ask you to label all of those. I just want you to know that as we go into the lungs, we say it's the bronchial tree. Just like trees have branches, the branches, when they branch out, you get more of them and they get more and more smaller, right? Like twigs. So this is what we call our bronchial tree. And it's not until we get to the terminal bronchi that we now have finished going through the conducting zone. So again, primary leads to secondary to tertiary bronchi to smaller bronchi called bronchioles. And when the bronchioles get so small that we now call them terminal bronchioles, that's the end of the conducting zone. Anything after them is part of the respiratory zone, which means this is where we can have gas exchange. So respiratory zone begins with a respiratory bronchiole. There it is right there. It's going to lead to these structures called alveolar sacs. These little honeycomb-looking structures are actually called the alveoli. That is the functional unit of the lung, the alveolus. This is where gas exchange is happening. You have about 1 million alveoli per lung. The surface area in your lungs to allow for gas exchange is the size of a tennis court. Weird to think that you have a tennis court of space in your lungs. And where are your lungs? Just so you're aware. Everyone's like this, okay? A lot of students go like, this is the space where, no, actually at the level of your nipples, that's where your diaphragm is. So your liver is way up here. That means your lungs are right here. Isn't that weird to think? When you inhale as deeply as you can, the apex of your lung can actually go around the level of your clavicle. Isn't that weird to think? You could stab someone here, like Basic Instinct style, with a ice pick, and you can cause someone to have a collapsed lung way up here. So your lungs squished it right here. You didn't know that, did you? Weird. A lot of times textbooks describe alveoli as being a cluster of grapes. I mean, it does look like a cluster of grapes, don't you think? But here's an important difference in that analogy. It's just an analogy and it's kind of weak. When you have a cluster of grapes, can't you pluck off an individual grape? right? They're independent structures. Alveoli are not independent structures. They share common walls. You cannot pluck off a single alveolus like you could a grape. Look, they share walls. They are not independent structures. So if you want to describe them as a cluster of grapes, that's fine. That's okay. As long as you know the important distinction, they are not independent structures.
Could you cut a piece of it off?
Yes, you can. In fact, people with a disease state called emphysema,
That's what I was
the alveoli, so let's talk about that just a little bit. Alveoli, because they share walls, that actually increases surface area. I'm going to give you an example of this. I used to have a neighbor, Dandy. She paints. She's a great artist, but she does a lot of impressionistic art. She would have a lot of people over. She'd hang her art on the walls of her house. She'd invite everyone over to look at her art. And she would get really frustrated as a hostess because she has an older house like I do. For those of you who don't know what an older house is like, we have these things called rooms. I know that's unheard of. I want an open concept design. I like my compartmentalization. I would not do well on HGTV. The producers would be like, we don't want you. Have you ever, I would like a compartmentalized house. That would be me. I like my rooms. Each room has a function. It's really important for my family because sometimes I have to say, everyone to your room. We all need a family break. You there, you there. Open concept, where do you go? Everyone's together. So she would get really frustrated because she had a house like mine where she had these rooms with walls. She would hang up her paintings on the walls. She would say, Kara, you know, I'm thinking about knocking down that wall and just having the family room and living room and kitchen all connected. And I said, that's awesome. That'll be great. Everyone can now move from one area to the next without having to walk through a doorway. But then where are you going to hang your paintings? Alveoli are like rooms. They share common walls. In some disease states like emphysema, they collapse one into the other. That's a bigger room, but you've lost surface area for gas exchange. When that happens, you have a problem. We say you have a problem with exhalation and gas exchange. That distinguishes you as a certain kind of breathing issue. Emphysema, bigger alveoli, they're also weaker. They can expand. You can clip those out. You ask, could you just clip them out? That's called a bolectomy. So there's the answer to your question. Yes?
So what happens when we get our collapsed wall?
I'm going to talk about that. Give me a moment. That's a great question. So let's look at the alveoli though before. Here are our rooms with a shared wall. They're pulmonary capillary beds, bringing the blood. In the air passageways, the alveoli, the oxygen is going to move into the bloodstream and CO2 will move out of the bloodstream into the alveolus, as shown up in this more up close picture. You have type 1 alveolar cells and type 2. Type 1 alveolar cells are the simple squamous epithelial cells that line the alveolus. Type 2 alveolar cells, shown here as these little kind of cells with little appendages to them, those are actually making surfactant. Surfactant is extremely important. And I'll explain why in just a moment. Well, no, I'll do it now. Many of you have water. Put some water on the tabletop in front of you. Just put some water down. Just a little drop. A little drop. A little drop. tiny little drop. There. Okay, little drop. Now take that drop, and I want you to spread it across your entire table. Let me know how that goes. Try and spread it across the entire table. It doesn't want to cooperate, does it? What does the water want to do? The more you try and spread it, what is it doing? So I heard contracting, okay? That's called the cohesiveness of water. Water molecules like to band together. And what you are seeing on your tabletop is water, liquid, now being exposed to a gaseous phase, the air above it. Water does not like that. Here's why. I'm going to act it out, okay? I'm going to act it out. When you have water in a liquid phase and it's exposed to air above it, some of the water molecules in the liquid phase are like, I see the light. I'm going to go. It's rapture. And the water goes from this liquid phase to the vapor phase. That's called evaporation. It's now in a gaseous phase, isn't it? It's changed phase. And the remaining water molecules that are in the liquid, that's what they're doing right now. Some of their buddies right now is going, oh. And the rest of them are like, no! No! Don't go! Everyone, kumbaya! Everyone, with me, down! Just keep swimming, everyone down! And that's the reason why in chemistry, when you had to read the level of a volume in a graduated cylinder, what were you always trained to look for? The meniscus! Where the water is looking like it's doing this, it's bending, right? It's because all those water molecules are like, no! Everyone, just keep swimming, it's gonna keep going. Stay with me, don't. And then some of them are like, no. No, don't come. Stay with me. Your chemistry teacher never described it like that, did they? But that's what they're doing.
Way better description.
So, in your alveoli, you've got water. And it's lining the alveoli. It's a mucous membrane. And that water in the alveolus is doing this. No, stay! And so in between breaths, your alveoli collapse. They collapse. Okay. How many of you wear contacts? Okay. How many of you know what a contact lens is? It's a piece of plastic that we put on our eye. And when we take our contacts out at the end of the day, it is so nerve-wracking. This is what we do. We're at our sink. Because now we have to peel this plastic off our eye. And see, and look, those of you who don't even know, look at the stress for everyone else. They're like, We have to apply enough pressure to peel this wet plastic from the wet surface of our eye. It's wet, it's water, where the water molecules are like, don't go! And you have to pull hard enough to overcome that without ripping off your cornea. And then, oh my God, and that's only half the battle. When you peel it off, you learn, like, whoop there. If you don't, release the pressure once the plastic is off your eye, you fold this plastic into a taco.
And you gotta make sure it's on the right side, so it's putting it backwards.
And then when you're new at this, you're like, oh shit, I got a taco now. I need to peel this back open. And for a piece of plastic, you're like this. And you have to overcome the all the water in between, like, no, don't go, don't separate. And you're like, you're gonna, and then you rip your contact lens in half. You do that once, and then you learn, oh, if I just add more water, then the water molecules are like, yay, more of us, kumbaya, and it opens up. Right?
Just drop it in the thing and
Yeah.
it just opens up on its own.
But that's after the first time. These are newbie mistakes. So your alveoli, when you exhale, they're like a taco. They're like the contact lens. Surfactant is water and oil loving. It's a mixture of both. So in your next breath in, you can open up your alveoli. Then you're not struggling for your next breath in. That surfactant isn't made until a certain gestational age. Babies that are born prematurely do not have enough surfactant. And to watch them breathe is horrifying, because they are now recruiting more muscles than the diaphragm and external intercostals. They are now using their erector spinae muscles. They arch their back, trying to open, and every breath in is a struggle. And they use more ATP because they have to use more muscles for contraction. And that's what kills them, is the fatigue, the struggle for every breath in. Isn't that horrible? So cohesiveness in your lungs, bad. Surfactant, good. The pleural membranes around your lungs, they also make a watery environment, the pleural cavity. That is also going to be cohesiveness from water. That's good. You need that. You need that. Here's why. Your lungs are not muscular structures. They aren't. They're elastic. They are a balloon. That is what they are. Can I put a balloon in front of you and say to the balloon, inflate? No? How can you inflate? How do you inflate a balloon, Cody? What? Show me. Demonstrate. Good, thank you. Oh my gosh, Sierra, you look like you need some air. Here. Now you do me. We don't breathe like that, do we? Yet our lungs are balloons. I don't see anyone taking, like, Olivia, give me a breath. Now I'll do you. We would never have lived beyond an hour if that's what we needed. When do we do that kind of breathing for someone? CPR. That's called positive pressure breathing. You are blowing up their lungs like you would a balloon. And yet that's not how we inflate our lungs. Isn't that crazy? So how are we doing it? How are we doing it? They're elastic structures. In order to get air to move from here into your lungs, Brandon, how does blood flow?
I don't know.
Guess how air flows?
I don't know.
Good. High pressure to low. Let's talk about the pressure of the air around you. Okay? The air around you has pressure 760 millimeters of mercury worth of pressure. It's called atmospheric pressure. If you go up to a mountain, there's less air above you, so there's less pressure. Have you ever taken food up to altitude and you see the bag of chips going, and you're like, what happened? Yep. 760 millimeters of mercury of pressure. When the boys were younger, they used to come in, like on a Saturday. Mom's home, she's not working. They'd come in, Mommy, will you make some pancakes and hash browns and sausage? And I would like, kind of, camera 1, camera 2. They're both still there. Boys, I don't think I can get up. Why not? The air is so heavy. How did you boys even get up out of bed? The 760 millimeters of mercury worth of air. How did you even get? And then the boys would be like, "'Cause we're strong, Mommy. Come on, Mommy, we'll help you." And so they would drag me out of the bed, and I would just go to the floor and just be like, "Oh." And then I can't. The air is so heavy. I can't get up. And the boys, they would get down low. They'd get down low, and they'd be like, "Mommy, we got the air. We got the air. Come on, Mommy." And they'd be like this. "We got the air." And then I'd kind of start getting up, and because they were little, we'd walk downstairs. They'd be like, "We got the air," and I'd be like, "Okay, you got the air. I don't know how you got out of bed. It's just so heavy." And so we'd walk downstairs with them like, "You okay, Mommy?" Like, "I'm okay." And then they'd get their chairs and they'd stand up on the chairs like this so I could cook at this. And they'd stand there like this. "We got the air." 760 millimeters of mercury worth of air pressure. It's so heavy. Air flows from here into our lungs. Air will only flow from high pressure to low. Okay, then how do you get the pressure of the air in your lungs to be lower than out here? That's Boyle's law. Boyle's law. Pressure and volume are inversely related. Pressure and volume are inversely related. That was something else I had to teach my boys too. They had to learn Boyle's law. I would take them into my office, small little office, small. I'd shut the door and I'd say to the boys, your air molecules." I didn't pick which gas, I just said, "Your air. Moving around like this." And then I'd start going, "Ah. Ah." And in my small little office, we had so much fun just going, "Ah," like body slamming into the walls and into each other. And I said, we're in a small little space. And every time we strike on the walls, that's pressure. We feel the desk, we feel the walls, we feel each other. It's pressure. Small volume, high pressure. Then I would take them into my bedroom, which is a bonus room. It's ridiculous. There's a bed. It's the size of this room. There's a bed, side tables, dresser, nothing else. The boys would play indoor soccer in my bedroom. The size of this room. I'd shut the door. I'm like, we are still air. And then we'd be, ah, ah, Bigger volume, less pressure, less strikes. Very boring, right? Pressure and volume are inversely related. Air will only flow from high pressure to low. So if you want 500 milliliters of air to go from here into your lungs, you have to make the pressure in your lungs be lower than out here. How much lower? How much lower? 1 to 2 millimeters of mercury. So if out here is 760 and you want to breathe air in, what pressure do you need your lungs to have? 759 or 758? Do you think of breathing as work right now? Most of us don't because we don't have a breathing problem. But when you breathe in, you have to contract muscle. Diaphragm moves inferiorly, external intercostals, opens your rib cage like this. Bigger volume. The lungs have to stretch. They have to be compliant with the diaphragm and chest wall. There's another way to blow a balloon up. You see my balloon? Sierra, grab a piece of it, just the edge. Cody, grab another piece. Olivia, grab a piece. Let's just start stretching it. And as we stretch it and the volume gets bigger, what happens to the pressure inside, according to Boyle's law? Goes down. Down, lower than out here. And the air will magically flow from out here into my balloon. And as we all stretch, I got the neck. I'm gonna tighten and it's inflated. Is that how you blow up a balloon? That's how our lungs do. Isn't that bizarre? We create the volume change first. It leads to a pressure change second, which leads to a flow of air third. That is not how we blow up a balloon. We create a pressure gradient first. We blow the air. And then we see a volume change. It's not how we inflate our lungs. It's not. Volume change first, pressure change second, flow of air third. The pleura, creating the fluid, makes your surface of your lungs tightly adherent to the chest wall and diaphragm. If the chest wall expands, if the diaphragm moves down, your lungs are expanded laterally, superior and inferiorly, and even anterior post. They're expanded. Volume change. More volume, pressure goes down, you breathe in. I'm nailing like 5 different questions in that supplement, aren't I? Mm-hmm. You know. I know. If we introduce air in the pleural cavity, in between the 2 membranes, Alexa, then there's no cohesiveness anymore. And your lungs do this, like a balloon. They're elastic structures, not muscular. I'm going to show you something.
Like fucking God damn it!
What?
Introduced air. Watch. There's the lobules. See the right lung collapsing? Air displaces water. Lungs. That lung.
Air in his chest is crushing his lung.
It's a thoracentesis tube needle.
Exhaust valve.
One-way stop valve, hear the air.
That feel better, man? That feel better?
He didn't really have to rehearse his lines. It was just say the same thing twice. Can you breathe? Is that
Air pressure's gonna build up about every 15 minutes.
So he had a pneumothorax. That means collapsed lung. Specifically, he had what's called a tension pneumothorax, which meant because of the position of his wound down here, every time he tried to breathe in, he actually was sucking air through the wound, getting more air in the pleural cavity, making that lung collapse. Each lung has its own pleural membranes and cavity, so they're independent. As that lung collapsed, it was pressing on his heart. And if we do not resolve that, like George Clooney did with the thoracentesis needle, it will cause cardiac dysrhythmia. It is life-threatening. It's not just an issue with breathing, but cardiac conduction now. So the thoracentesis needle, you saw him move the positioning of the cock stop. You heard the air come out. It's a one-way stop valve. Instantaneous relief. I've had a lot of military medics. They're given training videos. Many of them come in with their little thumb drive, and I tell them about atelectasis and pneumothorax, tension pneumothorax, and I tell them what's happening in physiology and patho. Like, I have a it's just like that movie you showed. I said, I know. That part of the movie was actually spot on anatomically and physiologically correct. They got everything right. Even with the placement of the thoracentesis needle, it needs to go up higher. And every once in a while, because he's still going to suck in some air, he has to relieve that pressure until he's at the hospital, and then they can seal that wound up and basically remove the air that's in between his lungs, in between his pleural membranes, and refill that with the fluid, the visceral fluid. So I hope that answers your question. Okay, almost done. So blood going into and out of the lungs for gas exchange goes through the hilum. That's the indented region. That's on the medial side of the lungs. And there are blood vessels that are going to the lungs for gas exchange. Those are the pulmonary arteries. And oxygenated blood leaves through the pulmonary veins. Remember, veins go back to the heart, arteries lead away. Whether or not it's carrying oxygenated blood is not the definition of an artery or vein. But then the lungs themselves are tissues, and they need oxygen-rich blood. So they need another set of blood vessels called the bronchial bronchial arteries and veins that are bringing oxygen-rich blood to the lung tissues for them to be able to do their job. There are nerves that go into the lungs. If you're running for your life, if there's a predator chasing you, would you like more lung capacity? Are you sucking wind? You are, right? That's your sympathetic division. That's part of your autonomic, your fight or flight response, your alarmed response. Sympathetic division causes your air passageways to dilate so you can get more airflow. When you're calm blue ocean, like right now, your parasympathetic division is more in control. None of you are sitting there, this is how I breathe every time, it's normal. No, you don't need that much air. You're not running, you're not doing anything. So your air passageways constrict. Do any of you have asthma? So Monday night, that's how this nastiness started. It was right after you left. Right after you left, I was sitting outside in the office suite with the students. I started coughing. I couldn't stop coughing. I was having an asthma attack. How many of you have asthma? What do you take for that? Albuterol. Albuterol is a chemical that will stimulate the receptors in your lungs that are part of the sympathetic division, and you bronchodilate. Then you can breathe easier. I did not have a rescue inhaler with me. I'm not prone to asthma. I can count on one hand how many times I've had an asthmatic attack. And you can still hear. Do you hear that? Asthma, emphysema, chronic bronchitis. Can you hear that? It's a problem with exhale and exchange. It is an obstructive disorder. That's why it's in COPD category, chronic obstructive pulmonary disorders. I can't fake that. Problem with exhale, obstructive disorder. We can go in the phys lab. We have spirometers. If you hook me up to the spirometer that can actually measure how much air I can exhale in 1 second, 80% of my exhale should happen in the first second I breathe out. Do you hear that?
You don't sound good.
I know. I would fail that spirometry test. They would say, you need an inhaler. What are you doing? 80% of my air is not coming out in that first second. And that's how we diagnose an obstructive disorder. Restrictive disorders, they can't breathe in. They have I don't have a problem breathing in. Listen, I don't have a problem. It's exhaling.
So asthma does that, but what does bronchitis do? Because that made me cough like.
Chronic bronchitis is still an obstructive disorder. Problem with exhale. You exhale, you don't need ATP. You don't need muscle contraction to exhale. You just relax the diaphragm. You just relax and it domes out. Most of us don't think of breathing as work, especially not exhaling. But if you look at me, I'm working harder at breathing out. I am using ATP for a process I shouldn't have to be doing. Does that make sense?
Asthma isn't obstructive, right?
Asthma is obstructive breathing disorder. It is one of the big three trifecta. It is asthma, emphysema, chronic bronchitis. Problem with exhale. If your problem is exhale, it's obstructive. And here's the worst part. The harder you try to exhale, the harder you try and push out the air, the more your bronchi collapse, the smaller ones, because they don't have cartilage to keep them open. So the harder you're trying to breathe out, the more you trap the air behind. That's why classic sign of having an asthma attack, what is it? Those of you who have them, what do you start doing? You're coughing. What does that show you? If you think your patient has a breathing disorder, all you have to do is watch them. All you have to do is watch. If they are working harder at exhale, they have an obstructive disorder. Asthma. Doesn't sound good, does it? I got sick just for you. What else did I just do? This is the tripod position. My hands are on my knees. I'm using abdominal muscles. I'm trying to shrink. I'm trying to press my lungs into a smaller volume. Smaller volume, what happens to the pressure in my lungs? Higher. Then it's higher than out here. And what can I do now? Exhale. Problem with breathing in? Well, already that's the work of breathing. You have to have muscle contraction to breathe in, right? We have to stretch our lungs open. Person who has a problem breathing in, they look just like Miku. They're like this. They're trying to make themselves big. Pulmonary fibrosis, where the elasticity of the lungs is now replaced with collagen fibers. They try so hard to make themselves big. Same thing with newborn, premature babies. Surfactant lack. They're doing this, trying to make themselves big. so they can breathe. Breathing in is not my problem right now. And I once tried to fake an asthma attack with my mom so I can get out of school. My mom's a nurse, okay? So here's my, and I'll answer your question. Mom, I can't breathe. Let me redo it. I was like, Mom, I can't breathe. Can you hear me? I can't. I'm having an asthma attack. And my mom's like, here's your jacket, here's your book bag, here's your lunch. Bye-bye. Exactly. In my sister's shoes, right? She knew because I was faking it for the inhale. It's not an inhalation problem. It's exhalation. And you can't fake that.
Why, when you get hit in the stomach like with a soccer ball or something, why is that not completely
So it takes your breath away,
Yeah.
right? And you land on your
Yeah.
It just basically is knocking down the electrical conductance of the heart. It feels like it's a problem with breathing, but it's really your heart kind of stopping for a moment, and you're like getting it going again.
Okay.
That's why. And that's a horrible feeling, isn't it? It's super scary. You're like, it's actually not your breath that's the problem. It's like your heart is going. So we talked about ventilation. Ventilation, breathing in, breathing out. Inhalation, exhalation. The work of breathing is supposed to be for inhalation. That's when you have to contract the external intercostals, contract the diaphragm, larger volume, lower pressure, air flows from high pressure to low. When you exhale, you just relax those muscles. When they relax, diaphragm comes up, lung volume is compressed. Now the pressure is higher in your lungs than out here. And all you need is a 1 to 2 millimeter mercury pressure difference, and you've got 500 milliliters of air coming in and out. What would you look like if you needed to get the same amount of air, but you had resistance in your in your air passageways? That's something called Poissonier's law. You don't need to write this down. Poissonier's law states that radius is the most important factor for flow. If my air passageways are smaller, I'm going to have less airflow. If I still need 500 milliliters of air, then I'm going to work harder. I am definitely working harder right now in front of you to exhale. That is a time when it's supposed to be passive. I'm working hard. And I'm not doing well, and that's the reason why I have to cough every once in a while. I need my inhaler. Didn't bring it. Respiration, external, getting air into the lungs for gas exchange. Then the blood is transporting the gases to the tissues. And again, in the tissues, we have gas exchange. That one's called internal respiration. Muscles required for breathing in. That's the work of breathing. That's where you need muscle contraction to get air in. Quiet breathing, normal quiet breathing, you contract the diaphragm, it moves interiorly, your lungs stretch. External intercostals, they move your rib cage like this, so you get expansion laterally, anterior posteriorly, and superior inferiorly. Larger volume, according to Boyle's law, means lower pressure inside. The air flows into your lungs. We create the volume change first. It leads to the pressure change second, then we get the air flowing. If you are doing harder breathing, you're on the treadmill, well then you're going to use more muscles. That's now you breathing with forced effort, even more effort. What do? You're going to recruit more muscles. The erector spinae, sternocleidomastoid, scalenes, all of those should be familiar to you at this point. When you exhale, normal quiet exhale, all you have to do is relax the muscles. But if you're like me, and now exhalation is work, Tripod. Abdominal muscles. Push your viscera up under the diaphragm, trying to make it dome even more to squeeze the volume of the lungs smaller, making higher pressure than out here, and then the air flows out. This is good stuff. This is definitely physiology. I don't want you to hear it for the first time when you get to physiology. This is one of the hardest systems in physiology. So I want you to hear it. That's why I gave you those supplements. Control of ventilation. And we're almost done. Control of ventilation comes from the brain, the medulla oblongata. Fact. There was a woman up in Sacramento. She was on a radio show. She was a contestant for a contest. Hold your Wii for a Wii. It was back when the Wii gaming system was new and everyone wanted one. And the contestants drank copious amounts of water. Nurses and doctors called into the radio station, begging the radio host, please stop this. You're going to kill them. They laughed and said that's the reason why we had them sign waivers. One of the contestants was a mother of 3. She did not win. She called into her office and said, I have a really bad headache. I'm going to go home for a little bit. I'll be in later. What was happening was, because of all the water she drank before her kidneys could catch up, before they can compensate, so much water got into her system, into her brain cells, that her brain cells swelled. And this shoved her medulla oblongata through the foramen magnum. And that's where your breathing center is. And now you've got this bony constrictor. She went home, fell asleep, and suffocated to death because of her brain center being constricted. Horrible, isn't it? Medulla oblongata, we have respiratory centers there. In physiology, you learn about the different centers and what they do. That is definitely not appropriate for us to go through right now. But on the picture here, you're seeing nerves in yellow going from blood vessels up to your brain. And these nerves, they are cranial nerves. There's cranial nerve 9 and there's cranial nerve 10, and you most certainly will be abused with those in a future date. And they are sending information up to the brain, not only about the blood pressure from those vessels that are close to the heart, but also the oxygen content. And if the oxygen content isn't where it should be, then that stimulates your brain to say to you, you need to breathe more. And the output command goes down to the lungs, actually the diaphragm and external intercostals. Watch me. Like, try not to yawn. Everyone behind you is going, no. If you wrote the word yawn, look! If you wrote the word yawn on your paper and then read it, hearing me say the word yawn, look at everyone's like, I'm not gonna keep saying it, yawn, yawn. Hear me yawn, see me yawn, write the word yawn, look at everyone, they're like, yawning is your brain telling you you need to ventilate more. That's what, do you ever notice that when you wake up in the morning, you yawn the most? Look at everyone still trying not to yawn. Did you ever wonder why? You're like, what the hell is that? I spent 8 hours sleeping. Why am I yawning? I'll tell you why real quickly. When you fall asleep at night, you don't ventilate as much. You don't breathe as much. And it's your brain that's monitoring the CO2 building up in the blood through these nerves. And if your brain wanted you to yawn, you would wake up from deeper stages of sleep in order to do that. You would not get good quality sleep. Your brain has to wake you up to do that. You can't yawn in your sleep. You can't cough in your sleep. You can't swallow in your sleep. To do those things, you wake up from deeper stages. So if you hear your kids coughing at night, they are not sleeping well. They're in low stages of sleep. They're not getting to restorative sleep. You need to address that cough. You have a sore throat and keep swallowing like the river of phlegm, then you're not sleeping. You cannot do those things when you're in deep stages of sleep. You cannot. So when you fall asleep at night, your brain, if it could talk to you, would say, we're going to let the CO2 build up a bit. It's okay. And that allows you to go into your deep stages of sleep, your REM sleep, your restorative sleep, your therapeutic sleep. Sorry. When you wake up in the morning, you have all this CO2 in your blood, and these nerves are sending it up to the brain, and your brain is like, right then, you're awake now? This is not okay. And that's when you start, and you're yawning, and you're getting that CO2 out. Look, everyone's yawning again. See, I don't take it as an insult. I know it's not because you're sleepy, it's because you're sitting in a room, you're not doing much, you're not breathing very much, you're just kind of there calm, and your CO2 levels are going up, and your brain's like, there's something you're not doing right now. Oh, that's right, breathe! And you start yawning. That's why. Ever notice if you're in a room, a lot of people, very poor airflow, and it gets warm, you start yawning even more, don't you? It's because you're sucking everybody else's carbon dioxide. Yeah, it's kind of sick, huh? So you heard me talk about asthma, emphysema, chronic bronchitis. All three of them are part of chronic obstructive pulmonary disorders. Cystic fibrosis, pulmonary fibrosis, surfactant lab. Those are a problem with inhalation. It's called a restrictive disorder. They got to make themselves big to get the air in. That concludes our lecture.